All right, so we'll go ahead and get started with this week's ultrasound case series presentation. Our presenter today will be Dr. Alex Sanoja, and he completed his medical school at the University of Arizona in 2021, and then he completed an emergency medicine residency at Mount Sinai Medical Center at Miami Beach in 2024. And during his residency, he was elected chief resident and also was awarded teacher resident of the year for his effort in teaching ultrasound applications and procedures. So he currently is an emergency medicine sports fellow at the University of Florida. And in addition to this, throughout his training, he's published several papers on rare ultrasound applications in the emergency setting, as well as diagnostic musculoskeletal ultrasound. And today he's going to be giving us a presentation on the EFAS exam for abdominal trauma.
Okay. Good morning. My name is Alex, and as Stephen mentioned, I'm from the University of Florida Sports Fellowship. Today we have a case about a football player who had a positive EFAST exam. So just to remind everybody, the objectives of the AMSSM ultrasound case series are listed below. And it's really to review a diagnostic ultrasound protocol of a particular region that meets criteria for a complete exam. This means that we will go over the images in detail and establish what is normal versus abnormal using the case as our kind of guideline. And then we'll review an ultrasound report at the end. Now, if you extrapolate that to this case, the EFAST exam is slightly different than probably all of the other protocols in this series, and that it's in the setting of trauma. So there are some core principles that are very important to realize before actually going through the protocol. We will spend the vast majority of the time reviewing the complete EFAST protocol, the nuts and bolts about it. And then we will, of course, discuss what is abnormal from the normal. And then lastly, we'll review the complete ultrasound report at the end. So some key principles to be aware of with this particular protocol include that this is not a comprehensive survey of the involved organs. Actually, in all actuality, there's really two things that you need to know about this exam. You are seeking to identify free fluid or air, so hemopneumothorax. That's it. It's designed to be fast, easily learned, and repeatable. And then lastly, a negative exam does not rule out intra-abdominal hemorrhage, which is a very important concept to realize. And as we go through the protocol, you'll begin to realize why. And I have papers that I'll kind of discuss with y'all as well. Another important thing to realize is that the probe of choice for the EFAST exam is the phased array, which is not a probe that we typically use in sports medicine. The reason for this is it has an advantageous footprint, can fit between the rib spaces, and is great for this particular protocol. And the preferred patient positioning is supine. All right, so here is the case. We have a 16-year-old football player who was tackled during a game, who immediately began complaining of abdominal pain on the sideline. The initial physical exam was actually unremarkable, and he was cleared to go right back into the game. He later pulled himself from the game due to increasing abdominal pain. At the end of the game, the athletic trainer repeated the abdominal exam in the locker room, and it was significant for left upper quadrant tenderness to palpation. Ultimately, he was sent to the ER with mom for increasing abdominal pain. In the local community ER, the EFAS was performed as the first diagnostic step, and the patient was upgraded as a trauma alert and transferred to our local trauma center here at Shands, where another FAST exam was repeated, and that is the FAST exam that we'll be going over today. Before we jump into all the different images and video clips from the case, I want to go through an overview of what the protocol includes. So there are 6 steps to the EFAST exam. The FAST portion is meant to evaluate abdominal and cardiac trauma, and that is the first 4 steps of the exam. So that's going to be the cardiac view, right upper quadrant, left upper quadrant, and pelvic views. Now the cardiac views, you have the subxiphoid and parasternal long axis view. It's imperative to know how to do both because you may not be able to get the subxiphoid view in a lot of cases because you're going directly underneath the sternum, and some people just cannot tolerate that, especially in the setting of abdominal trauma. So you got to know how to do both. The pelvic view, you also are getting two different views, a transverse and a long, and again, we'll go into detail about each of these. The last two steps, the fifth and sixth step, the right and left hemithorax, constitutes the extended portion of the EFAST exam, and that is to evaluate for hemopneumothorax. All right, so the first step of the protocol is the cardiac view, and you always start with the subxiphoid. And it is known that the subxiphoid view is the best for identifying pericardial effusion. So some pearls to know about with this view is that it requires a great deal of pressure to get an adequate view. And typically you need to increase your depth to get all the structures that you need to identify, usually about 16 to 18 centimeters at least. And the two structures that you need to know is the superior and inferior pericardial borders, because that's where the fluid is going to collect. Okay, that's where you'll see the pericardial effusion. So if we go to the image that I have here on the slide, the first thing that the probe encounters is subcutaneous tissue, and then you have the giant liver here, which is acting, which helps to bring the heart into view using an artifact called acoustic window. The first chamber of the heart you run into is the right ventricle. Underneath that's the left ventricle. Left ventricle connects to the left atrium, right ventricle connects to the right atrium. You have lung on both sides of the heart. And then where you want to pay attention to is the pericardium, which is this hyperechoic line here and is indicated by the red arrows. So if there was a pericardial effusion, you would see a jet black anechoic stripe beneath or above the pericardium, which we do not see here. So this is a normal labeled image here. Next, I have a video clip of what a normal subxiphoid view looks like. Again, you can see the pericardium up here, south and north, with no anechoic fluid collecting. Now, on our actual case, the subxiphoid view was not obtained because the patient had too much pain. This is a common occurrence. A lot of times in trauma, you're unable to get the subxiphoid view because of the mechanism and the injury. So you need to know how to do the parasternal long axis view to get a view of the heart and evaluate for pericardial effusion. So you would quickly move up to the fourth intercostal space. You're going to decrease the depth because you were just at 16 centimeters. And if you are using curvilinear, you certainly are going to have to decrease the depth. And this is where the phased array probe is really advantageous because it fits nicely in between the rib spaces and you can look at the heart. In terms of anatomy, the pericardium is highlighted with the red outline here. It is the hyperechoic stripe. And again, the right ventricle is closest to the chest wall. So that's the first chamber of the heart that you see. Left ventricle underneath that. Here you have the outflow tract, which is the aorta. And then you have the left atrium over here. This little circular structure here that's anechoic is the descending aorta. So a lot of times people may confuse this, but you know that this is an actual vascular structure because it's pulsatile and it is circular. So don't confuse that. Here is a video clip of a normal parasternal long axis view. And again, you can see that descending aorta coming in and out. And then here is the actual case parasternal long axis view that was obtained. So this is a really good image in the setting of trauma. You have the descending aorta here. You have the obvious white stripe here being the pericardium, and you don't see any anechoic fluid collecting underneath it. So this would be negative. And that is exactly what they said in their ultrasound report. Parasternal long axis view, no free fluid identified. The next view is the right upper quadrant view in the sagittal plane. So in terms of probe orientation, you're going to go to the mid-axillary line with the indicator pointing cephalad. And this is the easiest place to see free fluid. And Trendelenburg can improve sensitivity. But it's important to note here that it does require about 400 to 500 cc's of fluid to make this particular view positive. That's a lot of fluid. So it's an important concept to realize if you do see free fluid here in this view, the patient has lost a lot of blood. Important structures to identify here is the posterior pleural space, diaphragm, liver, especially the caudal tip of the liver, a right kidney, and the hepatorenal fossa, otherwise known as Morrison's pouch. It is impossible to get all those structures in just one picture, so I have two pictures here. The picture at the top shows the caudal tip of the liver, and this is where fluid collects first and is the most sensitive area to see fluid. So you must always capture the liver tip. Then you have the right kidney. In between that, you have Morrison's pouch. It is very easy to see fluid here. So it's an important structure to visualize. And then in the photo below, you are starting to see the posterior pleural space, and this bright hyperechoic line here is the diaphragm pointed out by the red arrow. And then again, you have the liver, kidney, and the rest of Morrison's pouch here. And this paper was just sought to see how much fluid would make a FAST exam positive in the pelvic view. They also noted that in the right upper quadrant view, it takes anywhere between 400 to 600 cc's of fluid to make it positive. The more experienced you are, the less amount of fluid you need. So this is a video clip, a really good video clip of a normal right upper quadrant view. So the liver tip is visualized very well here. You can see that the sonographer is moving the probe more cephalad to capture that posterior pleural space and diaphragm. And all the while, he or she is sweeping through the kidney to ensure that there is no fluid throughout that Morrison's pouch. I'll play it one more time. Yeah. All right, so this is the right upper quadrant view of the actual case. I'm going to play it here. It's rather quick. So in this view, unfortunately, it's a little suboptimal because you don't actually visualize the liver tip, and we just kind of talked about why that was so important. This is common in the setting of trauma. Often video clips are a little bit short. Now, the sonographer, the same person who did the scan, is the same person who wrote up the report, and they said right upper quadrant view, no free fluid identified. But again, it's suboptimal because although you can see the diaphragm and some of the posterior pleural space, you don't really see that liver tip, which is obscured here by this rib shadowing. The next view is the left upper quadrant view. This is definitely the hardest view to obtain by far. Usually requires the most time to get all the structures in view. The reason why it is difficult to obtain is because the structures are so posterior and your patient is lying supine. So the classic teaching is you want to put your knuckles to the bed and look up so you can see these structures. Things you can do to improve your view include breathing. So modest inspiration can counter the ribs that are just there. Here I have a photo that identifies all the key structures that you need to visualize. So you have the left kidney, spleen, the splenorenal space, and diaphragm. with the posterior pleural space coming into view. And here is a good video of a normal scan. You can see that the sonographer is having the patient take a breath in order to visualize the posterior space, and then the entire kidney comes into view. So this is a really good strategy they are using to make sure that they see every structure that they need to see. The diaphragm is this bright white stripe inferior to the spleen. This is the kidney, and you can see there's no fluid in this splenorenal space. All right, so this is the left upper quadrant view from the actual case. And again, it is a quick video, so I took still images that I'll pull up right here. And you can see that the red arrows point out where the free fluid is. So you have on the right of the screen, you have the kidney, you have the spleen, and in between you have this jet black line here, and this is fluid. Additionally, you have some fluid behind the diaphragm as well. So the ultrasound report reads left upper quadrant view, free fluid is present at the splenorenal recess in diaphragmatic space. I will note again from the previous paper that I had mentioned, it requires a significant amount of fluid to make an exam positive, on average about 500 cc's. So this is, so you know that this patient has lost a significant amount of blood at this point. All right, the next view is the pelvic view. This is the last view of the fast portion of the exam, which again, the fast portion of the exam is evaluating abdominal and cardiac trauma. In this view, you are going to get two views, a transverse view and sagittal view of the bladder, prostate or uterus, depending on the sex, and the rectum. It is very important, I will note here, to make sure that you get a sagittal view on every female. There are some people who only get transverse views on male, and then for females, they get both views, and that is because of the pouch of Douglas. The uterus is a very long, the rectouterine cul-de-sac is long, and I have a long view here, a sagittal view here, I mean, that kind of demonstrates that fact. If you don't get a sagittal view in a female patient, you are likely to miss free fluid. So what I do is, in my own practice, I just get both on everybody so I don't forget. So starting with the transverse view, you have the bladder on top of the uterus or prostate, and then the rectum below. Fluid is most likely to collect between the uterus and rectum, or prostate and rectum. In the long view, you have the bladder, again, over the uterus, and then colon, and you can just see how long it is. And again, this paper demonstrated that at the pelvic view, it was only required about 200 cc's to make an exam positive in this particular view. Another note about the pelvic view, this is the most dependent region for free fluid. So it's most likely to be positive of the four views. So I have two videos here in both orientations. First, starting with the sagittal view, you can see the uterus and bladder coming in and out. The sonographer is sweeping through it entirely to ensure that there's no fluid present. In the transverse view, the sonographer is doing the same thing, sweeping through the entire bladder, making sure that there's no anechoic fluid. Now, this was a normal model that we used. There, you may notice this like little circumferential black collection here. That's an adnexal cyst. Nothing, just something to point out. All right. This is the actual clip from the case. And there's a lot going on here, and it was a very short video clip that was obtained. So I took a still image to point things out. So you can see that the contour of the bladder is all kind of like messed up here. And then there's this circular structure in the middle of the bladder. Now, remember that this particular scan was done in the trauma bay, and we had already had fast views that demonstrated positive fluid, a significant amount of blood, So a lot of things, when that happens, a lot of things happen quickly in the trauma bay. So this circle is a Foley in the bladder. A lot of things happen at once. They're prepping the patient for emergent intervention. The red arrows here are pointing out free fluid. So you can see this little black dot, it's a small amount of fluid here. Then you can kind of see the contour of the bladder is just kind of all wonky. And this appears to be fluid that's tracking down into the pelvis. So the ultrasound report here says pelvic view, free fluid is present in the rectovesicular space. All right, so that concludes the fast portion of the exam. Now we are at the extended portion, which is to evaluate for pneumothorax and hemothorax. For the extended portion of the exam, you can keep the phased array probe. If you are just beginning to do fast exam, it may be easier to switch to a linear probe because it's higher frequency and you can see the structure so much more easier in the beginning. All that is required for the extended portion of the exam is one sagittal view of each side at the fourth intercostal space. The reason it's the fourth intercostal space is because this is the most anterior portion of the chest wall and the lung. So you are most likely to see a large pneumothorax here. So what you are looking for is sliding pleura, which is basically the visceral and parietal pleura sliding along each other. And presence of sliding pleura is a normal finding. If it's not sliding, then that indicates pneumothorax. So I'll play the video here. You can clearly see in our normal subject that the lung is sliding very easily. And I'll also point out, I'm going to play it one more time, that you have a rib here on the left and a rib here on the right. So very easy, the lung sliding. Oops. I may have skipped a step, but the ultrasound report's there, so I kind of ruined it. But this was a very quick image that they took during the actual case. And they ended up saying in the ultrasound report, right hemithorax, lung sliding present, no free fluid identified. Left hemithorax, lung sliding present, no free fluid identified. I'll play the video one more time. It's very quick. Again, you would like these clips to be a little bit longer. And that is why I included normal clips previously to show good examples of lung sliding. Okay. Now, when you are first beginning to learn the EFAST exam, it can be challenging to see lung sliding. And so there is an application of ultrasound called M-mode, which you may know from like pregnancy. They use this in OB all the time. We use it in echocardiography, but for the EFAST exam, it is very helpful to identify pneumothorax, particularly if you are a novice sonographer or if you have done less than 200 FAST exams. There was a researcher who wanted to see if M-mode was absolutely necessary for the FAST exam. And what they found is that if you use M-mode, you do increase your sensitivity only if you are new to doing FAST exams or have done less than 200 of them. So it can be very useful, worthwhile to learn. So that's why I'm covering it right now. So what is M-mode? Basically, M-mode is where you are basically using one sound beam and you are emitting that through the transducer. That sound wave then hits whatever tissue, bounces back to the probe, it is received, and then the machine graphs it out. So that's what you're seeing in the lower portion of the image there. You're seeing a graph. The x-axis is time, and the y-axis is depth. So in this picture, the pleura is at 2.5 centimeters deep. So if you go down to 2.5 centimeters on the graph, you'll see this line, which looks very choppy and interrupted. That is because the pleura is constantly moving. So when that sound wave goes through the pleura, it is being interrupted essentially. And so you get a very choppy signal that looks like sand. So they call this sandy beach, and that is a normal finding. Now, if there was no lung sliding and there, pneumothorax is present and there's no lung sliding, that sound wave would not be broken up so much, and it would look like a straight line, just like all the other straight lines above it, and look kind of like a barcode. So they call that barcode side. So sandy beach is a good thing. That is a normal finding, and it can be very helpful to identify pneumothorax in equivocal cases. So in summary, the complete diagnostic EFAST report, one of the simplest reports you will see in ultrasonography, concludes at the very end that there is a positive EFAST exam with free fluid noted at the left upper quadrant and pelvic regions. This is what these reports look like at level 1 trauma centers. Here at Shands, that's what it looks like. I also worked at Ryder Trauma, and that's how things are reported. Again, the mission here is to identify free fluid or air quickly. And it basically is a 3 to 5 minute exam maximal. Here, I thought it would be interesting just to show you guys the CTs because it was rather impressive. So I'll just spend a quick second here. In the arterial phase, both coronal and axial, there is active extravasation. You can see that little blush right here with surrounding blood products. And here's the blush here on the axial with mushed up bowel and surrounding blood products. Then on the venous phase, on the axial slice, you can see that deep laceration here. And that was the cause of his positive EFAST. So case conclusion, the confirmatory CT, which he was rushed to emergently, demonstrated a grade 5 splenic laceration and a mild liver laceration. He underwent emergent splenic artery embolization. Unfortunately, he failed that and required splenectomy 2 days later. He was then cleared to begin his return to play protocol after 3 weeks. Interestingly, there is this cynical paper looking at whether or not EFAST exam is necessary in hemodynamically stable patients. And what it found was that splenic injuries, being that it is a highly vascular organ, tend to give positive fast exams in hemodynamically stable patients. It's the only injury that was associated with a positive exam in a hemodynamically stable patient. And this is the last slide I have, conclusions from the case and going through the protocol. The EFAST exam is useful in scenarios where an athlete had a concerning mechanism of injury, but is clinically stable and does not warrant immediate transport to the emergency department for a CT scan. If an initial EFAST may be negative, as you learned, it requires a lot of blood to make an exam positive. So repeating the exam along with serial abdominal examination increases sensitivity. And once again, a negative EFAST does not exclude intra-abdominal hemorrhage. It requires a lot of blood to make an exam positive. Lastly, you must have a high index of suspicion. All right, that concludes my case. Any questions?
All right. Well, thank you so much, Alex, just going through the EFAST protocol, which I think is really high yield and helpful, especially to kind of use on the sidelines. Don't really have too many comments, obviously, about the protocol because, as you had mentioned, the protocol is kind of the protocol. For this. This is definitely one area that has been well established for a while. So I think it's just getting used to kind of those different views. I think the one thing that is a little bit of a challenge, just going from typically looking at the musculoskeletal structures to this EFAS exam is getting used to kind of like what you were talking about with the probe orientation. So it's just not going to be your classical sagittal, coronal, axial views. And I think that is just what we're so classically used to using in the musculoskeletal system. And so when you're doing the EFAS exam, sometimes you have to get creative, especially just in the setting of trauma, the patient being painful. And so just kind of as you alluded to, that's where I think kind of practicing going over this exam, kind of seeing the different probe orientations that you kind of have to use for this, are helpful. And then the other thing you kind of really highlighted that obviously I think is one nice thing with the ultrasound especially is this is not just a one-time examination, so if we're using this, especially in the sports settings, obviously this is going to be an extension of your physical exam and obviously your history with the patient that you can continue to repeat this, obviously on the sidelines. And of course, if they're getting more, free fluid and bleeding in that area, this is where the ultrasound can be really helpful just because you can repeat that examination so readily with the ultrasound on the sidelines. One question that I had for the thorax views when you're looking for a hemothorax, I know you had mentioned the fourth intercostal space that you were viewing at. Is there any utility to looking at, different levels, or do you only need to be looking at one level to kind of really be able to catch the majority of those hemothoraxes?
Yeah, that's a really good question. Your sensitivity increases significantly if you look at all the different lung fields. Um, so a complete lung exam would actually be 8 different spaces at a minimum, actually. And obviously, you're not doing that in a very quick scan. The point of those 2 spaces, the fourth intercostal space on both the left and right side, is to capture a significantly large enough pneumothorax that would require an immediate intervention. Because this was kind of created, ATLS 101, ABCs. You catch a large pneumothorax. Do you need to put a chest tube or not, kind of thing? Not necessarily to catch all types of pneumothoraces. So small pneumothoraces are not going to be caught with just one view. That can be missed. But you do increase your sensitivity if you look at, for example, the second intercostal space on both sides. And then if you go posteriorly around the mid-axillary level and look at the lung fields from that viewpoint as well.
Okay, yeah, thanks for that explanation. But obviously, I think it's good to kind of at least obviously have a home base and say, hey, at least if you're going to be, evaluating this, especially in a more stable patient, go to that kind of fourth intercostal space to kind of start out with.
Yeah.
So,
And just in general, Stephen, there's a lot of papers actually out about this. So if you get a supine chest radiograph that has like about 52% sensitivity for catching occult pneumothorax, and ultrasound has been shown to be superior to X-ray. So if you do a complete lung ultrasound that for pneumothorax on the sideline, that is actually it's very useful to know how to do it. Yeah.
nice. All right. Otherwise than that, I'm not seeing any other questions or anything in the chat. So I think that will conclude this week's ultrasound case series presentation. So once again, Alex, thank you so much for going over in detail the EFAS protocol for trauma situations.
Thank you, Stephen. My pleasure.